Okay, I'm happy to to introduce our next speaker. So Dr. Drew Moganaki, who is joining us from UCLA, a radiation oncologist, will be speaking to us on the topic of same particles, different result, the new age of image-guided radiation for lung cancer.
Thank you. Thank you, John. I hope you will learn something new about our discipline as we learn how to combine radiotherapy with drugs to optimize patient outcomes. So learning objectives, my hope is that you will recognize the workflow for treatment planning for the patients who come in our departments, understand the role of cone beam CT, which is critical for image guidance, and understand the value of image guidance. So I'll begin by clarifying the title here, which is that, oh John, we actually do not use particles. Instead, we use high-energy X-rays to induce the following damage to tumor cells. And I want to thank Tina for taking this picture of the two of us. So I want to dedicate this lecture to William Mayo, who a long time ago discussed that perhaps in the future some non-surgical method will be discovered which will not only be more simple in its execution, but more reliable in its results in a surgical operation. And we are making progress, but we're not there. This is what radiotherapy used to do to the lungs. This is a 90-year-old radiologist taught me that back in the days when he used to switch between diagnostic and therapeutic radiology, our treatments would induce what's called square pneumonia. And I recognize this is a rectangle. But in the old days, you could only just open up the beam and deliver it from the anterior or posterior portals. And of course, we didn't really know where the tumor was. There was a lot of collateral damage. And image guidance has helped us become more accurate with our therapies. So these are a series of pictures borrowed from the Memorial Sloan Kettering website, which describe the earliest machines used. You can see there's a patient laying supine, and there's some sort of apparatus aimed at the patient. At this time, X-rays were just discovered for diagnostic and therapeutic purposes. We were many, many decades, more than half a century away from first CT, and most of the image guidance was really surface anatomy. The machines became a little bit more powerful. The website of Memorial is very proud to discuss the delivery and receipt of large amounts of radium, and they would put all this radium inside this kind of sliding glass door that would open and then glow onto the patient, again, using surface anatomy for image guidance. This is, I believe, a Van de Graaff machine, and if you can see the pivot point of it, it kind of can swivel and go anywhere in the room, and there is literally like a little measuring stick that measures the distance from the surface to the machine to get some sort of approximation, and all of this was really hand calculated. I'm not sure even if the calculator was invented at this time. And then the technologies, we knew that if you could increase the energy of the X-rays, you could get deeper penetration, and you no longer prescribed to what was then called erythema dose, skin erythema dose. You would treat until the skin couldn't take it anymore, and you would stop because the maximum dose was on the skin. But if you could increase the energy, you could get depth penetration, and the Betatron, in its discovery, unfortunately, there's a very sad article written about many people in this discipline who were electrocuted, many of them fatal in the 1920s and 1930s to get these devices. And I think there were mostly electrical conduction problems to be able to overcome it. And I think a lot of these studies, these efforts were done, in this country as well as over in Europe. So we keep moving forward, and then you have this thing called, for image guidance, isocentric. So the machine now pivots around a single point in space in the room. So if you can put the patient there, this machine will always aim at it, no matter how it's rotating. But I was fascinated to see that the earlier rotation was done manually. Later on, it became kind of on a conveyor belt, like a carousel. Again, it rotates. And isocentric image guidance is basically the principle of how we treat today. The machine started to become a little more fancy in its design for architectural purposes. And then eventually, finally, the CT scanner became available. And this was now well after the only completed randomized trial of surgery versus radiation had shown a superiority of surgery because the radiation had been basically delivered without any sort of CT planning or even staging. So now this is kind of what things look like today. So after a very comprehensive history and physical, The patient slides through a CT scanner, and we get the images that we need, and they end up on the machine. And I've circled the most important part of these machines, which is the cone beam CT. So just real quick, what we do is we now can acquire what's called a 4D CT image. The fourth dimension is time, which allows this kind of video production. Now we know where we can aim the beam so the patient doesn't have to hold their breath for 10 minutes. During the 10 minutes of treatment, the beam will not miss the tumor. This is what a typical SBRT plan is. This is what maybe an IMRT plan is for a larger volume. And the toxicity of radiation really is much less dependent on the dose. It's much more dependent on the volume of disease. And this is why my surgical colleagues will tell you I often try to push my large volume patients to surgery instead of radiotherapy. So again, this is a cone beam CT machine. And when we design a treatment, here is a patient with a Pancoast tumor. And this is what we've designed. This is our virtual reality. When the patient comes to the room, this is actual reality. And you can see here, if you kind of squint, the tumor has already started to grow a little bit outside of the target. This patient was taken off the machine. We redid the plan, redesigned it, and make sure we capture that anterior section of tumor that has grown during the 30 days of treatment. So this allows us for three-dimensional alignment, confirmation, and accuracy, and we no longer create those square pneumonias. We are really just delivering to the target that we can see. Now, what's interesting is this term stereotactic radiation keeps being used, but it actually is a misnomer. It was originally introduced into our vernacular because we used to use these extra body frames that use stereotactic XYZ coordinates to approximate the location. And what's fascinating, if you look on the right, these are the type of images back in the 90s that the machine could take to try to approximate where is the tumor, using maybe ribs or carina as surrogates and using XYZ coordinate shifts to approximate it. And even with this old technology, it was with this that actually the first dose-finding study for lung SBRT was performed at Indiana University and the Indianapolis Veterans Affairs Hospital. This is Dr. Robert Timmerman, who led that study, who was able to show in the blue line the dose-response curve leading to local control rates unheard of and unexpected, nearing over 90%. And then on the red, you can see as the 3-fraction dose was escalated in his phase 1 trial. Very few phase 1 studies actually in our field, unfortunately, shows where the toxicity starts to go up. And literally, that's how we came up with the dose that is today. But the technologies that were used for stereotactic localization were very crude at the time. So this is what a modern linear accelerator will look like that provides incredible image guidance. Again, I've circled that cone beam CT image portal. And then we now have this kind of like surface trackers that can assess if the patient's respiratory or if they cough to turn off the beam. And there's all sorts of things to make sure we're not missing the target. So when the patient comes into a CT, our patients often ask, why do I have to get another CT? Well, it's a special type of CT. There's these lasers that are in the ceiling and on either side, and what they're used to do is to cast this kind of XYZ coordinate system because, again, we're planning everything around the single isosensor in the room that is checked every morning before we start treatment. It has to be less than 1 millimeter of reproducibility every single day. And this is where our patients sometimes get tattooed, and we tattoo according to these laser lines. And then the patient comes back to the room, and the laser lines are also all aligned to this isosensor. And I just want to remind, I have intentionally put a picture of a linear accelerator that does not have a cone beam CT. So if you want good image guidance, make sure that the therapeutic machine has a cone beam CT. It's very hard to know what's happening inside an operating room, if the surgery is good or not. Same with radiation therapy. But for lung imaging and image guidance, cone beam CT really is absolutely crucial. Now, there are other types of machine. Again, I've circled what is an X-ray portal. The CyberKnife does not use cone beam CT, so they're just taking an X-ray, and you can imagine it's difficult to see the precise edge of the tumor. They use various surrogates to, again, guide where this thing, and this robotic machine does not depend on an isocenter. It actually has 6 degrees of freedom and can aim from anywhere to make the treatment as precise and as small to minimize the toxicity. If you can deliver all the radiation just to the tumor, the patient will be just fine. But unfortunately, if you have to open up the jaws and treat more just to be safe, that's where we start to see more side effects. A quick word about proton beam therapy. So this is a machine that's a 3-story carousel. You are seeing the view of the second story of this machine. This is at Emory University, where I used to be. And so we have this kind of ceiling so the patient isn't in fear of this massive thing that's rotating around them. And same, once again, this kind of like device that's dropping down actually is an X-ray device that rotates, and they are now using cone beam alignment. Now, people so often ask, Drew, what is protons really better than X-ray therapy? Well, unfortunately, the early randomized trials at MD Anderson were negative, and there's lots of various reasons for that. But I just want you to look at an example case published on one of the Johns Hopkins websites. This is a very ambitious field to try to target, and on the right, this is typical X-ray therapy. So using proton therapy, which is actually a type of particle, you can see here there's a lot less bath of low dose crisscrossing through the patient. And we actually do occasionally send patients from UCLA down to UC San Diego, where my colleague Jim Urbanik is, and the patients remarkably come back with very little to no appreciable subjective side effects. And one of the fascinating things about protons is that they stop on a dime because they're particles. So here's a patient of mine where the beams are coming from posterior and they don't exit anterior. So right now there's a large national trial being run by the Energy Oncology Group, randomizing once again IMRT to proton therapy, and they hedge their bets because we don't think there's going to be an OS difference, and this is a co-primary endpoint of cardiac events. And I do believe that we will see less cardiac events because you can dial down the radiation incidental dose to the heart to literally 0 dose with this technology. And also now, a quick word about MR-guided radiation therapy. This is a technological tour de force. It's literally an MRI machine and a linear accelerator combined together. And if you can think about the magnetic fields would really interfere with a lot of the digital apparatus of a linear accelerator, but 2 companies have been able to make these machines, and this is the benefit of it. So this is my patient who's in the machine and cannot stop coughing, and I only want to treat their tumor when they are actually, when the tumor in yellow is actually in the red boundary. So we're going to deliver radiation to the boundary only, and if it ever moves, the machine, literally using some sort of AI-like image recognition, will turn the beam off so we don't miss the target. Again, allows for precise image guidance and not having to treat any more than we have to. A quick word about palliative image-guided radiation therapy. So here's a patient who's having progressive disease in the left hilum, the left upper lobe, and left lower lobe central bronchi are about to collapse. And unfortunately, the upper did collapse by the time the patient got to us. We designed a radiation therapy treatment, just a palliative course, and the airway opened back up again so they can breathe much better than they were. Image-guided palliative radiotherapy, we're really only aiming at what we need to and not anything else. And there's another type of particle therapy. This is considered a poor man's protons. It's electron therapy. It kind of sprays electron beams, and they don't stop as quickly as protons, but for someone, for example, with rib metastasis, you can avoid exit dose into the lungs. And this sort of image guidance also allows us to no longer treat whole brain. We can stereotactic just target individual brain tumors, which is a far departure from whole brain radiotherapy. And then in case you haven't seen this, just this image, we are now able to shape the radiation away from the hippocampus, which is involved with cognitive and short-term memory, and minimize side effects of radiation therapy. And also when it comes to spine metastases, we no longer treat one level above and below just to be safe. Because our image guidance is accurate, we can just treat the one area of bone that's a concern and really dial in the dose, more radiation to the target, less to the normal tissue. And then finally, you will probably not have heard much about this. Our institution, after I got there, I learned was putting needles into tumors with interventional radiology and sliding a radioactive seed into there for about 10 minutes and then pulling it out. This is a patient of ours who had a late progression after upfront SBRT. We put 2 needles in it, designed this treatment, and they're almost 8 years out now with no further progression. The tumor was thought to be too large for any other treatments, and the patient was medically inoperable. So John, now you know. Thank you very much.
So maybe I'll start with one question. I didn't see in this presentation TTF. We had a clinical trial at one point in advanced disease for tumor treatment fields where patients had to wear sort of vests or caps. And I wonder if that's something that's no longer being studied or advanced?
Yeah, it's interesting. So the company generally will provide that service as a contract, so we're not involved. So often medical oncologists will just call the company directly,
Okay.
and they just put it on the scalp or now on the chest, and there's not really much image guidance. It's more just kind of
Okay.
sending the fields in, yeah.
Okay.
It's interesting because when early studies came out, they did want to engage us into it, and I think it wasn't technologically complicated enough for us.
Okay.
And curious, actually, fantastic lecture. I have a meeting I'm going to invite you to. But what is your feeling about BID radiation, like twice a day? What do you feel?
I'm sorry?
Twice a day radiation.
Oh, twice a day, yes. So that's taking advantage of a biological principle where the small cells are really dividing so fast. And, you know, at this point, the bottom line is I offer both to my patients. So living in LA, this is kind of a first world problem. Our patients who live in Malibu, there's a lot of traffic between Malibu, the beachgoers, and so they'd rather come to LA and stay with their friends and just get it over with in 3 weeks, as opposed to go back and forth the Pacific Coast Highway for 6 weeks. So
And
there's
is there
been
a
no
rule-
measurable difference in acute or late toxicity between
Is
the
there a
two.
role in non-small cell?
For non-small cell, I think it has been tried, and it failed because, again, the biological premise is real, which there has to be rapid cell cycling to take advantage of that twice a day.
Thank you.
Yeah, great question.